So thank you so much for having me back. Again, my name is Renee Dwaihy-Logan. My Liggett claim to fame, other than being Allison and Gracie's mom, my most important job in life, is that I'm David Dwaihy's sister. So I use this a lot, like when I show up in the parking lot in the morning and I'm still wearing my pajamas. I'm like, well, I'm David Dwaihy's sister, so I get away with a lot. Because of that. So that's the Dwaihy part. I'm so proud of my brother. And the other part of my life, which has become more decidedly part-time since having children, is that I'm actually also a physician. I work, currently I'm at the Wayne School of Medicine. I work with what's called Wayne State University Physician Group. We're a group of academic physicians, and much of what I do is teaching. I do direct patient care, both outpatient and inpatient, but always in the context of a teaching team in an assistant professorial role at the School of Medicine. So, and I actually, teaching is a huge part of my career and a very valued part of my career, and has a lot to do with why I'm here today and my feelings about all of you as teachers. So I'm going to be highly repetitive. If any of you are here who are also here last time, I'm going to go over a lot of almost identical to what I went over last time. And then at the end, I've actually put together a document that hopefully we can disseminate, which will be a bit of a highlight reel. But the reason I am here today, again, is my background. When COVID hit, I was rounding in the hospital, and then I had a 2-week quarantine because I admitted the first patient, of course, by sheer luck. And after my 2-week quarantine, our clinics had shut down. So I moved straight into telehealth, and I was completely remote from the earliest part of the surge into June. Part of my role as a remote telehealth provider and teacher was that I got assigned to do the triage of our residents and fellows who became ill. So for many, many weeks, I ate, drank, slept COVID. We all were. We were on constant phone calls, constant emails, podcasts. We were trying as quickly as we could to learn as much as we could about this extremely mysterious little bugger. And in that role, by being at home, I was protected. I was isolated. I was also trying to homeschool and doing an interesting job of it. But so a big part of the reason I'm here today, I actually reached out to Bart over the summer and I asked if I could give this presentation, because as we started to talk about return to school, my first thought went to the teachers in their various personal levels of risk returning in person. My goal today, and the reason I'm here, is in hopes of protecting you in some way and really to honor you. I am the biggest Liggett fangirl. I am your number one fan. You see that one? I wore the same shirt, Rachel, but I did wash it in between. Because I value the people at Liggett as my children's teachers as the highest, with the highest regard in my life. I put them at the same level of my family. We've had a lot of very personal experiences. For those of you who know me personally, my older daughter Allison went through life-threatening illness when she was 6, and Liggett reached out to my family in a way I cannot begin to express or convey the feelings that I have. I'm sorry to be personal and emotional, but I see Lisa Cornell's face up there, so it brings back all those memories. And so my goal today, and the reason I'm here very specifically, is I want to acknowledge the fear that I assume most of you are experiencing. I want to hopefully reduce that fear, but I want to acknowledge it in a very significant way, because I want you to know that I personally felt it. I was super, super lucky that I was able to be fully remote until June. When I went back in June, we were not at zero COVID. I went back into the clinic where we were seeing COVID patients. and I had an overwhelming amount of anxiety. I joked a lot in the last session. I was trying to come up with all sorts of outs. The security guy was going to check my temperature on the way in, and I was Googling like ways to have a fake fever when it's not an oral thermometer. That didn't go so well. But basically, my personal anxiety was so high that it took a long time for me to reach a point entering the clinic on the daily basis, going through my personal protocols of how I kept myself safe. It took a long time for me to stop dreading going to work every day, to start to find the joy in my work, the joy in my teaching and in my patient care. I'm not 100% there yet. I won't lie. We get these little false alarms here and there where they don't properly triage a patient, or a patient isn't entirely forthcoming on the screening because they want to come in and be tested, and we're not a testing site. So for a variety of reasons, I still have a significant amount of anxiety. And so I identify with you very, very intensely in that regard. And yet, with the knowledge that I've acquired, I do hope that I can bring about a reduction in that fear through some really specific modalities that are going to be easy to institute into your daily life, and are things that we're not being taught. We're being yelled at over and over and over: mask up, socially distance, hand hygiene, and these become these punch words. But the reality is we're not going into the specifics on how to accomplish that in a meaningful way. So I really want to focus on that. I joke a lot about the weekend. I am mostly in clinic, but I actually round one weekend a year, which this year landed on March 15th, the Ides of March, right? Like, that was the very beginning of the surge. I saw the first patient at Harper Hospital. It was absolutely frightening. I had residents and medical students that I felt personally responsible for. And being the mother of a cancer survivor and having two elderly parents, I had and continue to have a great deal of anxiety. So I really want to approach it from that perspective. The fear is very real, and the fear is something that can guide our behavior in a way that we don't necessarily like. My husband and I joked, we both had imaginary COVID multiple times. I didn't actually have COVID. Thank God, I was very lucky. I had imaginary COVID several times. I had multiple pseudo exposures in my mind. This fear is a powerful entity, and it causes our rational minds to process in a very irrational way. So again, I want to acknowledge it, and I want you to know that that's actually a place that I'm coming from as an individual. Our family lockdown, the isolation brought back a lot of memories for me of Allison's illness, the germophobia, the inability to go anywhere, the lack of socialization, the reliance on the television. So I really hope that I can emphasize that a big part of my goal today is to reduce your anxiety, reduce your fear with tools, and increase your safety. That's my biggest goal today. So what I noticed, and what we all noticed very rapidly, because out of the gate, I was the triage doctor, right? Every resident, every medical student, every fellow in our internal medicine program, which is huge at the Detroit Medical Center, called me first line with their COVID symptoms. And I was doing this screening and writing them prescriptions to do drive-through testing and doing the follow-up and CDC-based guidelines. How many days do you need to be off, et cetera, et cetera. And at the beginning, they were dropping like flies. I mean, it was horrifying how many of them were getting sick, and unfortunately, in a couple instances, quite ill. Luckily, all of our residents did well, pulled through it, and then very dramatically, toward about the middle of April, everyone stopped getting sick. No one got COVID anymore of our healthcare workers. We started to get some really meaningful data on how to reduce healthcare worker exposure. And I'm going to try to extrapolate that for you today in the teaching setting, which is obviously very different because we now know how this thing behaves. We think we know. And again, I really want to be clear. I'm not a COVID expert. I'm not an infectious diseases expert. I don't think there is such thing as a COVID expert. this virus has been so tricky, so unlike anything else we have ever seen, that to have this sense that we understand it fully, we just don't and we can't. But I'm going to talk you through some strategies that will get you to walk into work every day and know my risk is at zero or at infinitesimally low. And you can know that clearly based on what you're doing and how you're doing it, based on what we now fully understand. And the reason that our healthcare workers, thankfully, are no longer getting sick. The final goal I have today is really going to be talking to you from the perspective as teachers. I have anxiety about our children's ability to perform these various self-protective routines, particularly the very young. Luckily, the very young seem to become a lot less ill from this. But my perspective today is really focusing on teacher safety, staff safety, faculty safety. We are talking a little bit, Nurse Rachel and I have spoken about putting together a program for some of the upper school and even middle school school level students who probably can do a better job of understanding and having a meaningful routine compared to the lower school. But today is all about your safety and what you can do as an individual. So I think we have this basic idea that, and again, I just kind of created this slide to highlight those points. We're going to talk about how this virus is transmitted and how we attack it at each of those points of transmission, how we can create overall lower risk environments, and then a very brief section at the end on how we can optimize our own immunity to reduce our risks. So there's this basic idea that you go out into the world. I mean, I know I felt this way out of the gate when we first came out of the hermits, came out of the cloud and opened the front door and the cobwebs separated and we re-entered the world. I think many of us internalize this idea, oh my God, like COVID is everywhere. I'm helpless. I'm going to go out and there's nothing I can do. I can follow all these rules, but I can still get COVID. And the reality is we should have that visual in our heads. Everyone is a PUI. In medicine, we're calling PUI patient under investigation. That means you're COVID suspect. You're COVID until proven otherwise. If we all walk around the world outside of our homes on the daily with the assumption that everyone is a PUI, we are going to be able to get to that zero. But again, the second part of that statement is not, but I'm helpless. The second part of that statement is, but I can stay safe. Everyone is a PUI, but I know how to keep myself safe without being in a bubble suit. I can keep my risk at zero or infinitesimally low by doing these basic things. And so I want to start, and I don't want to spend a lot of time on this because I got myself into big trouble last time with time. So I'm apologizing in advance for having a big mouth. But when we talk about how viruses spread in highly predictable ways according to the characteristics of the individual virus. So contact, your absolute classic contact via touch to a mucous membrane is chickenpox, herpes labialis, the herpes simplex virus that we get as cold sores. You get that by touching your lip and then inoculating the mucous membrane of another person. So the classic way that we transmit herpes is two people kissing, an adult who's shedding virus who then kisses a child, or feeds a child. It's all about touch into a mucous membrane. Droplet, the classic example of droplet infectivity is your classic common cold, viral upper respiratory infection, influenza. Droplets are the materials when a solid or a liquid moves across the air, it creates these small, around 5 micrometer suspended sections of material that carry virus. Spittle. I mean, it's literally what comes out of us when we cough, sneeze, speak loudly to the point where we're spitting in somebody's face. That's droplet. It's a large particle. And then aerosol is a smaller version of that same particle. So if this is just a visual, but I keep going back to it in my talk because I want you to have a really strong visual of the difference between a droplet and an aerosol. An aerosol is still a droplet. It's just smaller. It has broken down into a smaller particle. And the difference is that droplet was so big and heavy, it actually is going to fall to the ground. Gravity is going to act upon it, take it to the ground where it's going to desiccate and evaporate, and then either be dead virus on the ground or maybe partially active virus on the ground, but we don't care as much about that. It's the aerosols that are a smaller droplet, still solid liquid suspended in air, but now so tiny that the forces of gravity don't pull it down, and it sort of floats, it sort of clings in the air in this cloud. And we've heard a lot on the news about is this airborne? Is this aerosol transmission? We're going to talk a little bit more about it, but many viruses transmit via droplet, but very few via aerosol. The classic examples are measles, tuberculosis. That's why when we have a TB patient, we're all N95'd up and we're under aerosol precautions. We put a patient in a room with a negative pressure vacuum that actually sucks the air out of that room so that when we open the door, we don't get a gust of that aerosol out into the hallway to infect other patients. Fecal oral, this is my super favorite and by far the grossest form of transmission. This is what we think of when we think of like gastroenteritis, the stomach flu that we all get every November, somehow the week after Halloween, I feel like, and then one more time. So the fecal oral route is really where we are self-inoculating stool, E. coli mostly, into our oral cavity. Charming, I know, but if you visualize pre-K, the last talk, I spent a lot of time giving shout outs to Connie O'Brien and Julie Demchek and Kristen McLeod and Carla Witten and all of those beautiful pre-K teachers who know exactly what I'm talking about with the fecal oral route, a little hand down the back of the pants, and then it's the charming aspects of young childhood. Bloodborne, this is your HIV, your hepatitis C. Viruses are transmitted via direct blood inoculum, a needle stick in the hospital, or more commonly, needle stick via injection drug use. Sexual, I didn't put up here mostly because I couldn't find the best emoji for it. I didn't want Bart to get mad at me, but sexual transmission, obviously your HIV, hepatitis B, and then vertical is mother to child. So a pregnant woman can transmit HIV, rubella. These are the various forms. But how does COVID spread? We've got it narrowed down to just these four. And I promise you that the science is going to make more sense when we come into the practical aspects of why this is important. We know that the overwhelming majority of our COVID exposure are these two. And this droplet is contact droplet. Aerosol is a giant question mark. And they've actually done studies in the hospitals when we don't use aerosol precautions, we only use contact and droplet precautions. There were 0 cases transmitted. There is no doubt that this virus aerosolizes. They have proven it. But whether that translates to meaningful risk of infection, we really doubt it to a significant degree. But I'm still going to teach you how to prevent it. And then finally, fecal oral. It's within the realm of possibility that fecal oral can be at play with COVID, but it's so easy to prevent that I'm going to teach you how, but most likely this is not how it's happening. If we study the hospital rooms of COVID patients, they are teeming. The toilet handle, the sink, it's covered in COVID. They've swabbed COVID on every orifice of every COVID patient's bathroom. And when a patient isolates in the home, we tell them, if you got a big enough home with enough bathrooms, keep your own bathroom. But realistically, can the virus meaningfully spread? Just because we isolate viral DNA doesn't mean that's going to translate to active infectious virus. So again, not a meaningful risk, but one that we're going to eliminate. We talked about what is a droplet and what is an aerosol already. But again, the way we prevent is going to be very similar. So contact droplet spread. How does contact droplet spread happen? The classic example is I'm walking down the hallway. I am drenched in COVID. I have COVID, but I don't know it yet because I'm not going to get symptomatic for maybe 2 more days. But 2 days before infection, we know you're quite infectious. So I'm breathing COVID all over myself, all over the front of my body, my hands, my eyes. I'm a big blob of COVID. Then I see you in the hallway and I'm like, hey, buddy, fist bump, high five. Maybe I give you a hug. Now I have made physical contact with you And then how does that COVID transfer into your body? It's got to go direct contact, eyes, nose, mouth. So when we talk about contact droplet spread, meaning I the sick person, generated a droplet, it's on my person, and now I'm going to place it onto you via touch. It's almost always your own touch, and it's eyes, nose, mouth. So the overwhelming majority, 100%, let's say, I mean, truly 100% of contact can be eliminated by minimizing exposure to your eyes, nose, and your mouth. And that is something people keep saying, don't touch your face, don't touch your face, don't touch your face. But realistically, we all touch our face 32 times a minute. That's the average. I've seen a bunch of different studies. 32 is the one that I imagine is probably the most accurate because I've seen it the most. Of eye, nose, mouth, the eye is by far the highest risk portal. So here, when we're masked, we're less likely to touch our nose and our mouth because we're going to bump into something on the way, right? But the eye contact is something I really want to emphasize today, because if you are a glasses wearer, you still do one of these, and we do them subconsciously. So I really want to emphasize eyes, nose, mouth today, because really the lion's share of the exposure were direct, in the studies, were direct inoculum contact droplet, eyes, nose, mouth. And imagine all the different ways this happens. So, you know, in the lunchroom, for example, I know there's not going to be a lunchroom, the kids are going to be eating in the classrooms, but when we take our mask down and we're feeding ourselves, no, we're not worried about COVID in the food. Where we're worried about is our behaviors around eating. Hand to the mouth, touch the napkin, put that napkin down. I'm going to pick up your glass, and you just had your mouth on the rim of that glass. We talk a lot about inanimate objects, but when you think contact, there's a big difference between being in the grocery store, touching that box of cereal that maybe was touched 20 minutes ago, versus actively touching and handling the objects that an infected person has handled and touched with their secretions. So when you think contact, the prevention here is so easy. If you're not touching your eyes, nose, and mouth, you simply cannot transmit in this fashion. And masks and glasses and goggles and face shields are going to have a dual role. And a big part is just this direct reminder. When you do this, when you touch the mask, I want you to immediately wash that hand, and remember that we're going to think of our outside of our masks as contaminated, and I'll get to that in a moment. But when we talk about droplet contact exposure, we can take that to zero with certain reminders. If you're a kind of person, you know you're going to touch your face, go out and get some like glasses that don't actually have glass in them, or something refractive, get some big Jackie O lenses that'll cover a large portion of your face, just to remind you when your hand comes up, wait, there's a frame there. Oh yeah, it served its purpose. Goggles are great because they're really going to insulate the eye, but they're overkill. You don't need them. And we'll talk about the face shield in a little bit. So again, this is direct touch. When you are at home with your sick child, cradling them in your arms, and they have a fever, and you're mopping their brow, and you're feeding them and giving them beverages and touching them, this is how we naturally get contact droplet. There's no way around it. Okay, direct droplet. Now, I apologize for this absolutely charming slide, but I just had to do it. And I really want to emphasize how unlikely direct droplet truly is. You have to have this macroscopic droplet out of someone's yell, their cough, their sneeze, their loud speak, where they're truly spitting at you, and it has to go directly into your mucous membranes. Now, there is no doubt in my mind that this has happened in the world of teaching, and again, I would argue it's probably happened closer to the lower end of the lower school, right? And we all remember, those of us who have children, the first time that our child sneezed directly into our mouth, and you're like, okay, I know the moment that I got the cold was that glorious moment. Please take a picture and let's post it. If you're lucky, you'll actually get this lovely ring of material that actually shows up on your digital image. So again, you have to project that secretion into someone else's mucous membranes. So direct droplet spread, for a variety of reasons, is not a realistic method in most non-intimate interpersonal communications, right? Like, I mean, obviously, if you kiss your spouse, you're directly, you're breathing in close to their face, you're speaking into their face. Yes, this could happen if in a really intimate or close body connection, but realistically, in real life, direct droplet can be entirely prevented between masking and a 6-foot distance. I want you to now visualize this scenario where she's masked and he's masked. If he sneezes directly into that mask, he's going to get a huge amount of insulation of his secretions going out. And then she's going to get a fair amount of protection from her mask going in. Add to that a 6-foot distance, and you take that risk to 0. Okay. Aerosol spread, this is this weird one that we're not really sure about, these ultra small droplets that are truly floating in the air. So if you think about really close proximity, I'm within a foot or 2 of you in a non-ventilated room, and we're speaking, and maybe we're speaking in an animated fashion, and we're doing gross droplet, and we're doing smaller aerosolized floaty particles. In theory, this can transmit. And the reason I put this image in is you can see their talk bubbles are overlapping. So I kind of was visualizing the COVID bubble. Some of us have anxiety about, boy, I'm out and about. And, what if that guy walking 6 feet ahead of me just had COVID and he was speaking and breathing and it left a cloud? Realistically, this is not a real life transmission scenario. This is, but it probably has to be prolonged. It probably has to be, in very close proximity and in a non-ventilated room. So this is where you can see that the statistics show, how do we get COVID? We get COVID in our homes from another person within the house. So household transmission, non-PPE wearing healthcare providers, and then the number one, congregated areas. And I know that school is definitely a congregated area, but we can take these risks down to infinitesimally low by following these rules. Why are kids going to bars on the weekend and coming back with 5 cases? Because they're not masking. They're all over each other in the bar. They're in close proximity. They're breathing all over each other. They are inebriated possibly and doing all the things that people do when they're inebriating, including close talk and spit and intimate connected, all sorts of fun, right? So you can see how these little open bars and these parties that involve alcohol and drugs, it can result in just huge little peaks because you're violating every single one of these. Okay, fecal oral, the final one is, it is so easy to prevent fecal oral. There's 2 rules. When you're in the bathroom, let's assume that this toilet is coated in COVID virus. When you're in the bathroom, by doing your business and not touching your mucous membranes, and then immediately thoroughly washing your hands, you've taken fecal oral out. 100% all the way down to 0, right? Realistically, some people are papering the toilet. Is it going to get on the back of my thighs? What if my pants hit the toilet? Realistically, on dried surfaces, the risk is so infinitesimally low. If it's going to make you feel more comfortable to paper the toilet, paper the toilet. I paper the toilet. Okay. But again, that's public bathrooms. And then going back to sort of our pre-K butt scratch kind of scenario, again, if you are the teacher and you're the one that we're the focus of this talk, maintaining hand washing, if you have to help a child in the bathroom, if you are touching a child, just keep your hands out of your own mucous membranes and you're done, you're there. Okay. So we talked about droplet, we talked about aerosol. Contact droplet prevention is super, super easy, right? You don't touch your face. I want to give you a little bit of my comic relief here because everybody liked this part last time. So I feel like I owe you guys the, now watch me not be able to do it, right? Oh dear. Nope, that's not right. That's not right. Sorry, please bear with my tech issues. If anyone has a question while I'm doing this, now would be an okay time because hopefully I'll be able to think and talk at the same time, although realistically. Okay, here we go. Is this coming up? It says like tweet the Daily Show. Okay. All right, let's see if I can make it work.
First, keep your hands clean. Today, start working on not touching your face because viruses spread is when you touch your own mouth, nose, or eyes.
I've been looking around the room here. I can't tell you the number of you who put your hands to your face in the last 20 minutes or half an hour.
Washing your hands and not touching your mouth and your nose and your eyes.
The common sense of washing your hands, not touching your face.
Traditional rules of public health apply here. Just be smart.
So, obviously, oops, sorry. Stop. Obviously, that was tongue in cheek. And what I particularly like is the arrogance with which a couple of these guys, especially Dr. Ryan, he's like, I'm watching you all touching your faces. And then he's right up in there. Obviously, being zoomed away, we're allowed to touch our faces all we want. But, sorry, let me see if I can get this back up again. Okay, so let's try that. Is the PowerPoint back up, Nurse Rachel? Is that? I don't know what I'm doing wrong here.
It's up, but not full screen. So you
okay,
still
gotcha.
click through it.
So you see a person washing their hands?
Yes.
Okay. Okay, so let me just see if I can go back into, come on. Sorry, everybody. But it was worth that cute video, wasn't it?
Yes.
Okay, good. All right. Let me see if I can get this bigger. Okay, so obviously, do not touch your face. That was the take home. But recognizing, and I think with in addition to the humor, the video really does point out how difficult it is to do. Utilizing whatever tools you need to be successful with that. I want to move on now to direct droplet and aerosol. Again, it's mask plus distance. That gives you full protection. And then I want to talk a little bit about masks, and then we're going to move into the more robust part of the talk on masks. And that is that when you visualize your mask, I really want you to think of this mask as having a dual purpose. We talk, you hear about people saying, oh, masks don't work and masks don't, masks are imperfect. Masks are imperfect. But one of the best comparisons that somebody made that I heard in a professional lecture was comparing the protection to the layers of an onion and creating multiple layers that overlap, and in some cases actually abut one another so that there's a double protection in some cases, and acknowledging that based on your own personal risk, your onion needs to be smaller or bigger. So when we talk about the mask is got a dual purpose. These are surgical masks, and I'm really going to emphasize this on the final leg of the talk in terms of what I'm going to recommend. The surgical mask was designed for surgeons. Surgeons performing surgery put this mask on. They try not to do that with it. And the idea here is that I've just cut someone open, and I don't want to breathe my germs into their body hole that I just created, right? So this mask is designed, number one, and primarily to keep my aerosols and droplets in. Okay, so they are highly efficient at doing that. Surgical masks are also great in that they are waterproof, so that obviously if there's a bleeder in the OR and that blood squirts up, I'm not going to then have, an HIV or a Hep C exposure because I'm protected with a waterproof entity. But these masks, and all masks, including N95, are not 100% at filtering material in. So when you say, oh, I'm wearing a mask and here's the world of COVID and I'm breathing in X%, surgical masks get us to about 70 to 80% protection, depending on if they're the loop variety like this one, or if they're the tie back. The most critical aspect of mask wearing is fit. So when we talk about putting the surgical mask on, there's a metal bar in here that I need to mold to my big Lebanese nose, because I want this truly flush right here under my eyes. If it goes up too high, it's going to irritate that delicate under eye tissue. I really want a nice tight seal here, and I want to go all the way under my chin. The biggest mistake I see in mask wearing is the distance from the nose to the chin is inadequate. And I see it a lot in people wearing cloth masks. So one of the challenges, and you've seen this too, when you go places, you'll see someone wearing a mask that's just slightly too small, and they're often doing this. So they're like, "That's too low. Oops, too high." It's like Ned in his bed, and his feet poke out at the bottom, and then his head pokes out at the top. So the biggest challenge, and I'm having a real challenge finding Gracie the perfect length, because she's just in that. She just turned 7. The little kid masks are too small. The big kid masks are too big, and we're in the process of tweaking. But really, the biggest issue is you don't want to be manipulating this mask at all. You want a perfect fit, and you do not want to touch the mask. Because if we're extrapolating what we know about the hospital to the school, what we know is the highest risk period by far in a healthcare worker's exposure is in placing and removing their PPE, by far. So when we think about our mask, I want to kind of show you in healthcare language what we mean when we talk about perfect fit. So God forbid we could just speak like normal people. We nerd doctors have to come up with like our own special words. When we place our mask, it's called donning, and when we take it off, it's called doffing, like on and off with a duh. But you know, we've got to just sound so much more important that and then of course our patients don't actually know what we're talking about, and it's a great mystery. So full disclosure on that. So when we talk about placing our masks, if this is the area that has oh man, that went in my eye. If this is the area that has prevented 70 to 80% of material coming in, this is our contaminated side. And I'm going to illustrate that for you on this mask simply because it's 2 colors. So if I'm wearing my mask like this and my yellow is contaminated and my blue is clean, it's so critical that whenever I reach up to touch and adjust my mask, I have just washed my hands. If I reach up and touch my mask, I'm now contaminated my hands and probably further contaminated my mask. As this mask gets wet, it is no longer as effective at keeping droplet or aerosol out. So a wet mask is time to be changed. So when you go through the process, and you have to take your mask on and off, I want you to consciously think of this as being contaminated. So when you remove your mask, the order is hand hygiene, so 70% alcohol-based rub and let it fully dry, or better yet, a full hand wash. Then doff your mask, handling as little as you can, as far away from your face, okay? Now I have to store this in a way that keeps my sanitized part that I want to touch my precious face, right? These are my mucous membranes that I want to keep away the yellow side from. And so if you're wearing a cloth mask that you need to rewear, having a sanitized surface and putting it clean side up, or folding it in a way where you feel pretty strongly that it's comfortable. I personally pitch my mask every time. I go through 3 masks a day. I'm disposable. I'm sweating so much. By the time I am at my first snack, I hand hygiene, doff my mask into the trash, hand hygiene, I eat my snack, and I put on clean mask number 2. If you're going to use cloth reusable masks, maybe bringing 3 masks a day is in your best interest. It makes it less stressful to make sure that that clean part is clean and the dirty part is dirty, if you know where I'm coming from. Placing this in a UV area is better than nothing, certainly, and is probably pretty meaningful. But one of the things we see a lot of is this. This is called the Nancy Pelosi. It's like the choker mask, and she's got to have a silk one that matches the suit. This is a problem because no matter how clean your hands are, this whole process is imperfect. So as much as I know it's hard, and I want you guys to figure out ways to safely take mask breaks, it's the donning and doffing period that is the highest risk for healthcare workers and truly for lay people. And this is something that we don't focus on when we do our public service. Oh, wear your mask. Well, you've seen how people place their masks. They throw them on the table, they hang them, on a whatever. And again, it's really, really important that by minimizing the number of times you touch the mask and subsequently remove it, you are taking out so much of the risk. I want to show you, I took some photos at work the other day because this is real life use. So this is the surgical mask that I'm referring to when I'm looking at Raven here. And you'll see that Raven has the loops behind her ears. She does not have anywhere near a perfect fit up here. And she's got a fair amount of gapping here. Is that evident in this photo? I hope it's large enough. And And so again, there's a couple ways to minimize this gapping. First of all, this needs to be pulled up, which would automatically minimize the gapping.
You
The other
guys want
thing I
to eat?
want to comment on, I'm sorry, go ahead. Did somebody have a question? Okay. These little devices, which are readily available, will allow two things to happen that optimizes the wear. This is Natasha. She has a lot less gap here, and this very uncomfortable, this skin behind the ear is so sensitive. The first couple days I came home, I thought, is the back of my ear bleeding after 12 hours of mask? I was totally miserable. I have very sensitive skin, and this piece of elastic has some synthetic fiber in it. I got to the point where I'm like, I was Vaselining the back of my ears. I finally gave up, and I actually moved to these, which are tie-back surgical masks. I like these for two reasons. Number one, they bypass the ear. And number two, they do create a tighter seal. When they studied these head-to-head to this type, these were slightly superior. Again, in terms of availability, you can turn this into this by simply getting one of these devices and creating a longer stretch back. That's going to take out a lot of this gap, and it's going to take away the pressure from your ears. I've seen women and men with headbands where they have two buttons here, or head caps. If that's what's going to work the best, I think that's a really good option as well. We're probably going to do that with our kids. The reason I'm going to recommend this so strongly over the cloth mask is, number one, cloth masks are highly variable. If we're looking at 2 to 3 ply, the studies show that the very best are a layer of cotton, a layer of chiffon, and a layer of cotton. That got you 40 to 50% protection. This has got you all the way up to 70 to 80. Any cotton material or poly or chiffon is going to be incredibly hot. These are going to be miserable to wear, and they're not going to have the same tight seal here or here. So I know that Liggett School has provided these masks, and you can purchase these online. Most of them are shipping from China, which I know causes mixed feelings. I let mine ear out for a couple of days. That made me feel better. These are waterproof. When these get wet, that 40 to 50% protection goes down to much, much lower. You can just imagine a wet cloth transmitting a droplet versus a dry cloth stopping a droplet. So these are waterproof. These are much more breathable. These are designed for a surgeon to wear for 7 hours, these are not. And heat comfort, they're cooler. So again, if you can get over the issue with the ears, these are a decent second. They come in multiple plies. You want to really optimize fit and think about how many times you're going to take them off. Okay. Again, not touching the mask, not fiddling with the mask, and then constantly going through your mind, hand hygiene, doff, hand hygiene, don, hand hygiene, and then a place to keep your mask where it's not going to self-contaminate and not go down around your neck. The kids are going to have lanyards to put theirs on. I am not as confident that a child can as meaningfully you should have seen Gracie at the pediatrician yesterday. She managed to get up the nose, around the corner, under that mask. She self-contaminated 15 times, and I thought, oh dear God. And again, realizing that children are not capable at various ages of doing this. The important thing with the child wearing the mask is that it's protecting you. It's giving you that 70% plus, well, let's pretend this one's surgical, 70 or 40% plus 6 feet gets you to 100. That's what we're really going for there. But for the teacher to keep it on and then place it in the safe place is really going to get you to where you need to be. Talking about hand hygiene, alcohol-based hand sanitizer, it's got to be 70% or better, and you've got to let it dry. That is, Mommy's giving her talk, so 1 more minute, Angel. The alcohol-based hand sanitizer is great, but the hand wash is preferred. And if you can hand wash, if you've got both options, do your hand wash. If you only have alcohol versus nothing, do alcohol. The reason the hand wash is better is there's the additional element of rinsing away. In alcohol-based hand sanitizers, this wipe is a 70% product. I use this when I have nothing else. I use this to disinfect my phone. But the problem is this is incredibly drying to the skin. There's actually studies that show that when you do alcohol on your hands multiple times a day, you actually start to get some absorption into your bloodstream, especially in a broken down skin. So again, washing your hands, if you have a sink in your classroom is definitely more ideal. Some of these come with emollients in them, and that's also a nice option. But again, if it's alcohol, you got to let it dry. But ideally, a nice warm soap and water, 20 seconds, sing the birthday song, and reinforce that for your kids. Surfaces are not as alarming because as we tend to visualize them, is because, again, if we're following the rules and we're not doing eye, nose, mouth, doesn't matter what's on those surfaces. But again, COVID is exceptionally easy to kill. So by continuously dealing with high touch surfaces, your phone, your iPad, anything that you're touching throughout the day, that's going to take that risk down even lower. Okay, so we talked about masks. I alluded to mealtime. When they've done studies on how people get COVID, the highest risk is within a household. It's not as high as you think. It's only about 10 to 15% household transmission with a known COVID patient. Unfortunately, those studies didn't break down, whether or not those families were doing various things, but most people would think it would be 100%. As easy as it is to transmit, it's harder than I think is being sort of expressed in the news media. I think there's this real hysteria, like, oh my gosh, it's so easy to get. The reality is, when they studied people in close conversation with that direct droplet or aerosol, those numbers were infinitesimally low. People needed to be in very enclosed quarters for an hour to 2 hours in extremely close proximity. There was a study that showed that a bunch of people singing in a choir transmitted at the early phases where people weren't masking. Well, if you visualize between droplet and aerosol in that proximity, you can see how that happened. Food sharing is something that I want to talk about. And I also want to make one comment on touch. As teachers, I know that there's a tremendous amount of close contact that is different from many professional settings, right? You touch your students, you reassure your students, we hug our students, we hug our children. As a parent, it makes me very happy that my children's teachers hug them and are nurturing to them. And I won't lie, a big part of my angst about them going back in this setting is that so much of that will be removed. There will be times when we can't control it. If you're in the pre-K and you have a child that's having a meltdown, crying, screaming, again, doing what you need to do, and then acknowledging that if you hand wash and you don't during that period wipe your brow or rub your eye, the risk is still very, very low. Having a couple extra masks on hand, maybe even having an extra shirt in the school for you as that extra layer of comfort. Real life is going to happen. Real life is going to happen in pre-K, and real life is going to happen in first grade and second grade. And again, we're going to have to operate within the realms of what we do as teachers. I teach 20, 30 somethings. I tend not to hug and cuddle them all that often. But I know that a big part of teaching in a lower and middle and all the way up to upper school is interpersonal connection. So again, I kind of want to emphasize that. Now, two other layers that we didn't talk about much, but I want to talk about very briefly is the N95. The number of 95 comes down to the fact that, unlike this, which gets us somewhere between 70 and 80, and this cloth mask, which gets us around 40, these N95s have an incredibly tight seal when they are properly professionally fit tested, and probably filter out about 95%. N95s create such a tight seal, and they're designed to be single use. They're designed to be used for about 5 to 10 minutes when you go in to handle a TB patient, suction a TB patient, suction a measles patient, and now a COVID patient. I go in that room, that patient's getting a breathing treatment, they're on oxygen. Aerosolization is happening at a higher level. I need this protection. Nurse Rachel's going to need an N95 if a kid comes into our office having an asthma attack, vomiting, she needs to give a breathing treatment. But the second this outer surface gets moisturized with those very aerosols that we're trying to protect us against, these are really not designed to be worn all day. We have, in the context of the hospital and PPE shortages, placed one of these on top of one of these to make it last longer. But realistically, the comfort level is so poor. Some physicians and nurses were actually getting skin breakdown in the distribution. And and there's actually some concerns about oxygen exchange and CO2 retention. I personally, if I am walking into a known patient's room, those are the guidelines in our hospital. But what we are doing that's much more meaningful than an N95 and much more realistic is the addition of the face shield. This is me. This is my glamour shot here. This is me at work. And the reason I took this photo is, number one, I wanted to show you these tie backs and how they work, that the back of my ear is protected. You can see there's a much tighter seal here. And the face shield is hot and it's uncomfortable. And I sweat under this. But wearing this, I can go 12 hours in this. I cannot do an hour in an N95. And because I'm in an outpatient clinic, this is actually what the hospitals have approved for areas where we might potentially have patients who have COVID. If a patient is known COVID, or we're going to do something to them, we're going to give them a breathing treatment, put them on oxygen, or swab them, we're going to put on N95s, and we're going to put on a water impervious gown and go full PPE where we look like we're in spacesuits. But this gets you very close, because if you remember that droplet image and you imagine the cling of the aerosol in the air, you now have this 70%. Now you have a mechanical barrier over this that is your mini walking plexiglass. So for those of you who are incredibly high risk, or have a high risk person in your home, or have a high level of anxiety and can tolerate this discomfort, this combination, the face shield plus the surgical mask, is going to get you very, very high levels of protection. Again, we talked a little bit about mask breaks, doing it safely. Doing a mask break outside is an infinitesimally low risk thing to do. If you have a little bit of a period of time, I know that those students are still having their specials, but they're not necessarily going to their special location. But when you have this downtime, going outside, hand hygiene, doff, hand hygiene, and breathing some fresh air for outside for 20 minutes or 10 minutes or whatever you've got is really going to be helpful. Again, remembering the onion and the fact that the onion has to be as thick as it needs to be for your own personal risk. I also have these things that I think of as like making me feel better. And I'm pretty sure there isn't a CDC guideline on what feels good for COVID protection. But again, you know, when I come home from work, first of all, I strip all this off. Then I actually go to the bathroom, take these dirty scrubs off, put them in the dirty receptacle. I put on clean scrubs. I get in my car, I drive home in my clean scrubs. Then I take those off and I isolate those for 72 hours. And then I take a shower. Yes, I am beyond over the top. 90% of this is what makes me feel good. It makes me feel better to take a shower. Obviously, I don't put a phone up to my ear at the hospital anymore. There's no way to do that. You can only talk on a speakerphone. I'm not touching my face, but when I get home, instead of taking my showers in the morning, I simply take them at night. It makes me feel better. Is it critical? Did someone do a study that said that changing my clothes and changing my clothes again? But I'm taking care of sick patients, right? Patients come in when they're sick. Being in a school with students, if it's going to make you feel better on your way out to change your top and maybe wash your face after you've doffed your mask, and that's a solution that's not particularly expensive or wasting a lot of resources, I don't think there's anything wrong with that. Again, you're talking about moving an infinitesimally low risk situation. You know, how likely are you to have dried material on your clothing that could realistically transmit virus? Infinitesimally low. But if that final drop to zero is going to make you feel better, do it. And then practical considerations, being outdoors, having the windows open, HEPA filters when you're indoors, UV light. My mom always used to say the solution to pollution is dilution. I think that had more to do with opening the door after using the bathroom than COVID. But the idea being that when you have a finite number of COVID viral particles in a three-dimensional space, by opening that space, by creating additional airflow, you are taking a low-risk situation and making it infinitesimally low. Masks outside, again, because of proximity, they're still recommending it, but I think there's a real good chance that we're going to see the guidelines change for masking on children in the near future because, again, of all those imperfections we talked about and realistically what we know about the rate of their viral spread. My last point, and I know I went way over and I'm really sorry. Oh, I went way over. Oh God, Nurse Rachel, I'm really sorry. I have a couple words that I want to say to you and again, no slant on this. This is what I'm seeing in the hospital. This is what my colleagues are seeing. This virus is weakening. It is different now. I don't know if it's because we are catching it earlier, knowing exactly what to do out of the gate. We have several tools to use. We are not seeing anywhere near what we saw. In terms of both how the virus is presenting, we're not hospitalizing people anywhere near as frequently, and certainly not moving them to the ICU. We're sending them home. People are not getting as sick. There's something about the virus, and it's, is it because it's a younger population? There's 1.5 million different theories. But I really see an end in sight right now. I am a pathological optimist. I am fully admitting that. But between the timing of where I think vaccines are going to go and what's happening in terms of where we are on the curve and where the trajectory is, how effective the virus is at infecting multiple people because of some partial herd that we have achieved just by the sheer number of people in our population who've had it. The end is in sight here. And I think that as many of these interventions that we're doing, there is going to be an end in sight. And I think that investing ourselves in them heavily to keep ourselves safe, to reduce our anxiety, we're going to be able to move through and push toward a more positive place. And then my final point is I really want to encourage you to reach out and contact me with specific questions, with personal situations that, maybe are outside of the realm of this context. If we do still have a couple seconds for questions, Rachel, if anybody has any.
Yeah. Do you see? There's a couple in the chat. Do you?
I forgot about the chat.
No, that's okay.
I was on such a roll there. Okay.
You were, and they came at the end.
Okay. Oh my God. This is the bane of my existence, fogging up glasses and the face masks. And I wish I did. I know that there is something about placing this lower, like my rims land pretty much there. I'm constantly fogging. The face shield can eliminate some of that, but there's going to be the first 10 minutes where you're fogging constantly. And what I do with my face shield a lot is I actually lift it, and like a welder, my plastic welding uniform, I lift it, and that seems to help a little bit. But I wish I had better answers to this. And the answer is no. I'm sure that there's if I can find a hack, I will definitely let you know. Was that it on the chat? Fogging, face shield. Did I answer the questions on N95s versus, was that pretty good? I've seen people in N95s and it's not wrong. Several of my colleagues at work in the clinic where we don't have, where we know we're not going into a known PUI situation and that patient's been pre-screened in the non-COVID part of the clinic, and obviously that process is imperfect. The guideline is surgical plus face shield, and I have a lot of friends who wear an N95 and a face shield. I have no idea how they tolerate it, but again, they do have to put this on top to allow that modification to be able to wear it longer. Oops. Uh-oh, I clicked something and bad things happen. Let me see if I can get back to the chat.
Oh, the chat.
Sorry, I know something else. Did somebody else have a question? If you can unmute yourself and
I do have a question, Renee. This is Brad Homuth.
Hi.
And thank you so much, first of all. This is so helpful to hear, and I feel much better knowing what I can do now, whereas I didn't feel like I did before. So thank you, first of all.
Good. I'm so glad.
This is a specific question for me and kind of my family situation, but my parents are the primary caretakers for my grandfather, who's 90 years old, and that's been a big concern. And as we've started to go back to school, we've kind of agreed to kind of isolate from each other.
Yeah.
I just would be curious or interested to hear what you would say about, like, as long as I'm taking careful precautions at school and my daughter's in kindergarten at school, what would you say the risks would be for contaminating or exposing my parents and my grandfather through them?
100%. That's such an excellent question. And I'm really glad you asked it, because I had a train of thought that I don't think I completed. So when we talked about those household transmission rates, which again, statistics have had us all over between 6%, 15, and some studies will show higher, but again, those studies are so imperfect because we don't know what the household conditions are. Where we have gone in terms of caring for our patients, if I have a known COVID positive patient, I did a telehealth visit, or I saw them in the hospital and I send them home, what we are instructing our patients, and these are CDC guidelines, when you enter your home, you are absolutely, full steam ahead, cleared to return to a home with other people in it. What we recommend is that you stay in your own bedroom, isolated, ideally with a window so that you can have some ventilation in there and not, that you have the ability to release a little bit of that virus, that you utilize your own bathroom, and that when food is brought to you or taken out of the room, that appropriate channels are used. And then when you walk out of your bedroom or bathroom area, that you are masked. Masking the COVID positive person is what's super critical. The only time we are telling people move out of the house, if that's an option, is if there's somebody in the house who's profoundly immunocompromised. When we talk about risk, there are these layers of risk. And I've heard people, friends of mine, oh my gosh, my husband was at work and his boss's wife had COVID, and then blah, blah, blah. So when we think about that link and that tracing, if you are not directly exposing you or your daughter to the 90-plus-year-old great grandparent, you have taken the risk down to negligible. By doing what we just talked about. Now, again, your kindergartner is incapable of, unless she is some super uber genius, which she may be. Don't want to take that out of the possibility. But realistically, as a normal, healthy child, she's going to self-inoculate. At her age, she is so low risk for developing symptomatic infection, but if she were to develop asymptomatic infection, she could still potentially serve as a carrier. So if you and your daughter have any contact with your parents, making sure that you're asymptomatic at that time and following the rules. And again, I would, for the foreseeable future, not have direct contact with great grandma. Again, is the end in sight? Initially, the conversations about the vaccine availability, we're talking about November, December. And so that's why they kept saying not until 2021, because realistically, we weren't going to be able to mass inoculate until January. There are some unofficial grumblings. And again, I don't want to say anything official. I don't know anything better than anybody else. But there's been they are alluding to the possibility that if there's such strong efficacy in the phase 3 clinical trials for the vaccine, that just like they did with remdesivir, ethically, they had to stop that trial and say, this drug is working so well, we can't continue to give people drug and placebo. It's not ethical to withhold drug from these placebo people. So they started giving everybody remdesivir. They continued the trial, but they did what was called a premature cancellation because of an emergency. So what will likely happen with some of these phase 3 vaccine studies, and the real possibility that we could be vaccinating people like great grandma by October, which would mean conferred immunity within 2 to 4 weeks. She will be first in line. I, as a healthcare worker, get to go first. And then, but again, I have a feeling that based on availability, teachers will be very, very front line on this. So by vaccinating all of us, and we've talked a little bit about me maybe coming back and doing a vaccine talk, because I know there's a tremendous amount of anxiety, but my take home is I will be the first in line, and I will throw down with people who try to get their shot first. There is an end in sight that's a lot less than what necessarily was originally being projected. So when we think about this, and I just had this conversation with my parents, both of my parents are in their 70s and very high risk. So we've talked about now no longer the children cohorting with my parents once they start school. But again, this could be January, February, but this could also be November, December for great grandma. Somebody pointed out very appropriately that yes, frontline, high risk, there's a very real possibility that it's going to be longer, right? If it's January to March, that's now 6 months away from great grandma. But those sacrifices have to be made. We are protecting her, and we're protecting your parents. We're protecting your parents because I'm assuming that they're not in their 20s. And as that risk echelon goes up, the risk definitely increases. There's two other things that I'm going to mention in my handout, and I'll mention briefly. With regards to optimization of immunity, vitamin D supplementation. And again, I want to be careful. I don't want to give anybody formal medical advice. I'm not your provider. But what I say to my patients is there is no doubt that statistically vitamin D has been shown to offer some protection against viral infections across the board and specific to COVID. The science is weak. Where the science is strong is that if you are D deficient, you are statistically much more likely to have severe disease with complications. So vitamin D supplement is a no-brainer. The measles, mumps, and rubella vaccination, this is an area of real interest that might get rolled out in a bigger way. And this is something I would ask your personal physicians about. There are some hospitals in certain high-risk areas. I have a friend who's a physician in Georgia. They're giving everyone an MMR booster. A lot of adults, their immunity wanes from MMR anyway, and because there have been measles outbreaks, we've been really focused on that. But there are some really interesting studies out of Hong Kong and Madagascar where they had measles outbreaks. They did huge pushes for public health MMR vaccination for adults, and they're seeing inexplicably low COVID rates, extremely low death rates. In the case of Madagascar, the last time I saw the data, 0 deaths. So there's something protective. Is it any vaccine? Or is it specific to MMR? Again, getting a flu shot, absolutely critical for 2 reasons: the protection of against co-infection, and we do genuinely believe that anytime you get a vaccination, there's this upregulation of your immune system. After you get your flu shot, how do you feel? You kind of feel lousy. You're a little sore in your arm. You may feel like you're coming down with something. You may feel like you have a low-grade temp. That's your body's immune system responding to that protein antigen to make these little antibodies against it. But there's this idea that every time you activate that immune system, it sort of sits higher. When you get sick, that immune system sits lower. Your immunity gets compressed from the stressors of an illness. But by doing it through vaccination, there's this thought that there's this up-titration of the immune response. So in the clinics lately, we've been giving everybody a vaccine that we can justify for a couple reasons. One is there's another surge in the fall. We don't want people walking around unvaccinated and having months added to the period. And then of course this theory, it's not proven. There's not clean science behind it, but we consider it benign and something that we would do anyway. So Brad, was that a decent answer?
Yes, thank you so much.
Okay. And certainly vitamin D for all those folks. Any other questions? Let me make sure I double checked in the chat.
Thank you so much. This was so very helpful.
Oh, I'm glad. I hope I was able to convey. I think the first time I gave it, I was funnier, and but I was also I was so rushed because initially I had planned a longer talk, and I think maybe I was able to cover things that I had been stressed that I didn't cover the last time. So maybe it is good that we recorded this one. But I'm going to have to go back and dig out some of those jokes because I was so focused this time I wasn't as silly.
You were funny.
I was?
You were funny.
Okay. I told my brother in the first
my
one,
second time seeing you.
I said, stop muting.
Hearing.
I said, when I'm funny, unmute me so that I can hear you laugh. So then I have the feedback to know so that I can then be subsequently funny again. It's so hard because, one of the things with working with these residents, hearing these horrific frontline stories. I was never in the ICU, but they all have post-traumatic stress disorder. It's absolutely horrific. And I don't mean to make light of any of it because the human lives lost and the tragedy of how those lives were lost with no one by their sides, no funerals. I saw so many patients via telehealth, families. Most of my patient population is an underprivileged inner city Detroit population, and that population got absolutely brutalized by this thing. I talked to patients who had gone to 4 or 5 funerals, virtual funerals, and I don't mean to ever be dismissive, but we are stripped down emotionally as humanity. We have gone through this terrible time. And there's been so much fear. There's been so much daily stress. And sometimes, I think being silly and making light of it, and, we're doing it a lot at work. There's been a lot of face shield welding jokes, because it's so important right now, I think, to reconnect at a human level. And that's why, despite all of my anxieties about the kids going back, and obviously in our personal situation, it took Allison's oncologist to say, send that child back to school because you're going to drive her crazy, and that's going to be worse. But really, so much of my decision to send Allison back with her history came about from my knowledge of how Liggett operates, the fact that this is a small private school, the fact that there's such attention to these issues, and my genuine feeling that them being back in person and reconnecting with other kids and reconnecting with their teachers who they absolutely adore, that health for a child, when you look at that risk-benefit ratio, it's just so important. Thank you for having me. I appreciate the opportunity.